It's important for us to establish patients with high-risk disease because it's an unmet need. And by high risk, I'm not just talking about the genomic landscape of the disease, although that is very important. That does highlight those who do not get the durability of response from modern day therapy, as one would expect when you look at standard risk patients. But also it includes people who've got clinical high risk features. So they may have a normal fish-derived karyotype, but when you actually treat them, they either they don't respond as well, or that response doesn't last long. And those we often refer to as clinical high risk. And other features that are biologically inherent to high risk disease include the evolution of plasma cell leukemia, particularly primary plasma cell leukemia, and also people who've got extramedullary disease. And one of the things is that a lot of the developmental drug clinical trials look at high-risk disease much more in the context of the genomic landscape rather than these other entities, because they're quite often excluded from clinical trials. That said and done, when we move forward to the current era of really exciting new agents, namely the immunotherapeutic agents that are targeting T-cell redirection therapy, then a lot of these trials are including people with clinical high-risk disease as well as genetic high-risk disease. And we're already seeing some patterns where treatment combinations, for example, Eculizumab, Lenalidomide, Dexamethasone, can be used with patients who've got genetic high-risk markers, and they respond just as well as patients who do not have said genetic high-risk markers. And we are starting to see that same equivalence of response and response duration with some of the immunotherapeutic agents. But what was interesting for me was some of the data that was presented at ASH, the tail end of last year, which highlighted people with extramedullary disease included in the CAR T-cell projects as well as the T-cell engagers. And while the responses aren't as good as those who do not have EMD, nonetheless, there is responses there with patients with EMD. So we are starting to make inwards into hopefully designing better clinical therapy pathways for people with high-risk disease.